Welcome to this explainer. Today, we're diving straight into the deep end of the kidneys to demystify three major tubulointerstitial diseases. These are the notorious culprits behind intrarenal acute kidney injuries. If you've ever looked at renal failure and wondered what exactly is breaking down deep inside the kidneys, well, you're in the exact right place. Today, we're breaking down acute tubular necrosis, acute interstitial nephritis, and renal papillary necrosis.
Here is our roadmap for the day. First, the interrenal culprits. Second, acute tubular necrosis. Third, acute interstitial nephritis. Fourth, renal papillary necrosis. Fifth, spotting the difference. And finally, number 6, treating the root cause.
All right, part 1, the intrarenal culprits.
To start, we really have to ask ourselves, what exactly causes an acute kidney injury from the inside out? You know the pre-renal and post-renal causes of AKI, right? But what happens when the actual structural tissue of the kidney itself is the primary problem?
The answer? Tubulointerstitial diseases. These conditions damage the deep, microscopic plumbing of our kidneys. And get this, they're responsible for a massive 85% of all intrarenal acute kidney injuries. It's a huge deal.
Moving on to part 2, acute tubular necrosis, or ATN, the heavyweight champion here.
Here's how this one plays out. When these cells are starved of oxygen, they undergo necrosis. They die and literally slough right off into the tubular lumen. Think of it like a physical dam being built in a river. The hydrostatic pressure builds up backward into the capsule, which makes new filtration basically impossible and causes your glomerular filtration rate, or GFR, to absolutely plummet.
You can group ATN into two main buckets: ischemic shock that starves the kidney, or direct nephrotoxic poisoning. So, whether we're talking about a massive drop in blood pressure from, say, cardiogenic shock, or direct damage from aminoglycosides or myoglobin in rhabdomyolysis, the end result is exactly the same. Now, because these damaged tubules lose their ability to respond to hormones, you're going to see a classic clinical marker, a fractional excretion of sodium strictly greater than 2%. Normally, hormones like aldosterone trigger sodium reabsorption. But in ATN, those tubular cells are dead. The body's signals just cannot work on dead tissue, so all that sodium spills right out into the urine.
On top of that, since the necrotic cells can't reabsorb water either, patients will present with a highly dilute urine osmolality, specifically less than 350. Without functioning cells to pull that water back in, it just stays in the tube and gets flushed out. The result is very dilute, low osmolality urine.
All right, part 3, acute interstitial nephritis, or AIN. Think of this as the allergic battleground.
Unlike the internal blockade we saw in ATN, AIN is more of an external squeeze. An antigen enters, binds to a protein, and triggers a massive T-cell hypersensitivity response. This floods the interstitium with cytokines, causing severe edema that literally pinches the tubules completely shut from the outside.
To remember the common triggers, you'll definitely want to lean on the darn sap mnemonic. Sure, infections or autoimmune diseases can technically cause AIN, but in the real world, medications, most notably your beta-lactam antibiotics and NSAIDs, are overwhelmingly the most common culprits that kick off this hypersensitivity.
While they don't always present together in reality, the medical literature places a massive emphasis on this classic diagnostic triad: fever, a morbilliform rash, and eosinophilia. If you see a patient who recently started a new antibiotic and suddenly develops these symptoms alongside an acute kidney injury, AIN should immediately jump to the top of your differential.
Let's travel even deeper into the kidney for part 4, renal papillary necrosis, or RPN.
This condition is an absolute plumbing nightmare. Ischemia at the very tip of the renal pyramids causes dead tissue to slough off and get physically stuck in the ureter. But instead of just clogging a microscopic tubule like an ATN, large chunks of this necrotic tissue physically break off and fall into the major urinary collecting system. It acts exactly like a severe kidney stone. To keep the diverse causes of this deep tissue ischemia straight, use the postcards mnemonic. The mechanisms at play here are fascinating. In sickle cell, malformed cells literally jam up the vasa recta. In diabetes, arteriosclerosis narrows the path. Even chronic NSAID use restricts blood flow by inhibiting vasodilating prostaglandins.
Okay, part 5, spotting the difference. Let's look at their clinical fingerprints. When it comes to urinalysis, the differences between these three are pretty stark. you'll see the muddy brown casts of dead cells in ATN. Then, you've got the eosinophil-rich casts from the allergic swelling in AIN. And finally, macroscopic sloughed tissue with hematuria in RPN, which, by the way, is usually accompanied by significant flank pain as the kidney swells up behind the blockage.
If your patient has sickle cell or chronic NSAID use and shows up with macroscopic hematuria, a CT urogram revealing a signet ring sign will confidently lock in that RPN diagnosis for you. Because RPN involves larger structural damage, imaging becomes incredibly valuable to spot that distinct necrotic cavity right at the tip of the papilla. And that brings us to our final section, Part 6, Treating the Root Cause.
Notice how the treatment fundamentally shifts based on the cellular culprit. For ATN, it's all about hemodynamic support, getting them fluids and vasopressors, and strictly avoiding nephrotoxins. AIN, on the other hand, being an allergic reaction, requires you to immediately discontinue that offending darn sap drug. You'll also want to consider early corticosteroids to calm that immune response down.
And for RPN, you absolutely must target the underlying systemic condition from the postcard's mnemonic, whether that means strict glycemic control or putting them on hydroxyurea. If the sloughed tissue is already dammed up the ureter, a urologist might actually need to surgically place a stent to hold the pathway open and bypass the obstruction to save the kidney.
So I'll leave you with this thought. Considering how incredibly quickly these distinct conditions shut down filtration, could mastering these microscopic cast differences be the ultimate key to reversing an AKI before permanent kidney failure sets in? By simply understanding whether a blockage is coming from dead cells on the inside, immune swelling on the outside, or necrotic tissue wedged in the plumbing below, we can tailor our treatments to be incredibly precise. Thanks so much for joining me for this explainer, and as always, keep staying curious.